Welcome to our conference today, brought to you by Smart Dog Productions. We're going to present a case that's really interesting. That's multimodality, which is what we want to commit to here, is multimodality imaging. So we have a guy who's 53 years old who was sent for a third opinion. He lives in Plant City, moved there from Maine, and he's been a very active guy, walking 2 miles a day, has a long history of palpitations, a long history of cardiac disease, going back to childhood. At what time a murmur was discovered. Palpitations seem to be related to exertion and also seem to be relieved by rest. And so he's not had any other symptoms of any sort, and he's followed cardiologists for years. And so we're not sure what this story is going to evolve into, but let's talk a little bit more. He had an echo and stress test done in Maine in the early 1990s, said he had a leaky valve. He's gotten treatment for pranolol, not sure what was being treated then verapamil, had a stress echo in the past. We don't have those results. Everybody gets a SPECT scan. He had a SPECT scan. I don't know what it means about a moderate size, severe apical defect. Not sure what that means. I'm not sure what most SPECT scans need. So, because they're false positive, false negative, and so forth. He does have a systolic abnormal of 35%. I'm not sure what that means on a SPECT scan, but and they showed no regional abnormalities. I'm not sure what that means on a SPECT scan. So let's move on. He has a cardiac cath, so we can look at his cath. And of course, it's inevitable that a guy, I'm not sure why he didn't get a cath earlier. It's inevitable that he would get a cath showing up with these symptoms going back so long with such chronicity. And so here's a coronary angiogram that shows normal coronaries. Looking pretty good. LED distribution is pretty normal. Right coronary looks great. Nothing else seen. Left ventriculogram, and so doesn't look normal. There's that little bulging area, the anterior lateral wall. That doesn't look normal. The apex doesn't squeeze normally. The posterior basilar area doesn't squeeze normally. Anterior wall's moving pretty well. So there are some things wrong with this ventricle. I'm not sure why we see what we see. There's a little distortion there in that little like diverticulum of the anterior wall. And so not a normal LV-gram, certainly not quality for ejection fraction. You can guesstimate it at 40-something percent, 45. And so let's go back to our slides. So cardiac cath, no obstructive coronary disease. And LV ejection fraction, I thought there was some regional areas. I'm not going to call it global. I thought there were regional areas. A lot of people can't see those. I think there are. Aggressive medical therapy, risk factor modification. I'm not sure what we're aggressively medical therapying and what the risk factors we're modifying. For aortic regurgitation, we're going to do risk factor modification. That doesn't make any sense. Anyway, that's what they said. So let's move on to get some more information about his history. So hang on here, and we'll see what else we can tell about him. Well, unspecified cardiomyopathy for 20 years, so their ejection fraction problems have come up time and time again in this gentleman. Non-smoker, no significant smoking history, a little bit of alcohol, walks a lot, and he's on standard treatment for low ejection fraction or not normal ejection fraction, carvedilol and lisinopril, so not very high doses, and some aspirin for some reason. Not sure why he's on aspirin. And so his physical examination, basically diastolic decrescendo murmur. It was pretty easily heard, so it must be pretty loud. That's it. Here's his EKG. Let's see. This is a very, very interesting EKG in that there's very prominent voltage all over the place. So he qualifies for LVH easily. He's got a bunch of Q waves scattered around that are somewhat deep and wide, and so that's abnormal. His T wave axis, so it looks like LVH is strain type EKG. We used to see ST and T wave changes, ischemia / digitalis, but nobody's on digitalis anymore, so we don't have to say that. And so very abnormal EKG, a lot of voltage. Septum is depolarizing from left to right, so that's normal septal depolarization. Looks like the QRS is a little on the wide side, so a little IVCD coming in there. And QT looks normal. And ST segment elevation across here. So certainly with this voltage, you wouldn't think that he has infiltrated cardiomyopathy. So there goes amyloid, sarcoid, hemochromatosis. So let's look at his echo. Echocardiogram, basically to look at his aortic regurgitation. There. Again, this is really not the best place to see that. But we'll look and see that the septum looks kind of big there. Definitely big septum, out of proportion to the posterior wall. And so forth. Very prominent septum. Not so prominent in this view as it was in the other view. You can roll through here. Not much mitral regurgitation. There's our AI. We can let that play for a minute. Some AI. There it is. This is not a very good image for showing the aortic regurgitation, but there's some AI. It looks like a tricuspid aortic valve. Normal coronary origins. Big, hunky looking, chunky looking septum. Be hard to get this thing to keep playing. So that's our echo. Let's go back to our slides. So since you couldn't see everything the way we played that, we've got left ventricular hypertrophy. It's called concentric here, but it certainly looks like the septum is out of proportion to the posterior wall. Probably type 1 diastolic dysfunction, A wave greater than E wave, greater than 0.8 ratio, RVLA, RA normal, moderate to severe AI, moderate MR, average global longitudinal strain, normal. We don't have a lot of patients with normal average global longitudinal strain, although regionally there was some abnormality, the septum, which I didn't show you, and few PVCs. Maybe that's the source of his palpitations. MRI. Let's look at his MRI. I think you're getting used to seeing these MRIs. This is called a survey. This is where we take pictures, coronal, sagittal, and axial, for heart location, to get the heart central in our imaging. So this is like a finder, trying to find the heart, get it in the center of our field. And so we do that with these quick images. So they're really not of diagnostic quality. There's a lot of motion artifact. And they're basically, we're looking at the heart rate, we're looking at the respiratory rate, and we're looking at the central cardiac image to get our bearings. And so that's all we're doing. And so then we do our first ejection fraction measurement. And we do our first long axis image.
and doesn't look like it's squeezing well concentrically. So it's just sort of blah. Looks like that 40% ejection fraction. The long axis isn't even shortening. There is thickening along this area. This area is not thickening at all, right in the mid-pivotal area of the septum anterior wall. There's no thickening as there is here and here. So something's wrong with this ventricle. This looks like it's moving along pretty good. The long axis isn't shortening. This area now is beating normally. Not much mitral tricuspid regurgitation. And looking at these images, this is the stack. This is a stack of short axis images from which we calculate the ejection fraction, which is the gold standard for ejection fractions because it's 3D. And it's a stack of images with very well documented endocardium. So that's how this got the claim to be the gold standard for ejection fraction, and it is. And there's some areas that aren't beating well or even distorting in terms of their conformation. They're not changing. So it looks regional, although we know there's no coronary disease. What we see here, and there's something wrong with the twisting. The torsion isn't right at the apex. And you always look at the first apical segments for torsion, which is counterclockwise as we see it here. And so we're right here, we're looking for torsion. It's supposed to be counterclockwise. Something wrong with the torsion. It didn't move counterclockwise. Something wrong with that. And then there's some regional LV dysfunction. It still looks like about 40%. Here's a chance to look at aortic regurgitation. It's somewhat diffuse. It's not like a jet. It just sort of comes in diffusely. Doesn't look like it's wide open. It doesn't just drop. Left ventricle squeezing well. Might be dilated a little bit. This is for the right ventricular outflow tract, although we see some of the left ventricle as well. We're focusing here on the right ventricular outflow as well as pulmonary artery, pulmonary valve. As we look at this, we get a pretty good concept of the relationship of everything, and we also see that we're not seeing the possibility of any SAM or any outflow tract abnormality, although we claim that there's some abnormal septal thickness. Let me stop this one. We also look for edema, which is acute process, and we go around looking for edema, which is useful, and somebody who's had a cardiac event, say somebody has edema but no light gadolinium enhancement, and so in that case then they would have stunned myocardium. This is our look locker. So let's look at this. This is when we do we have the heart in a magnetic field. We send a signal in, and the signal comes off the coil. The signal goes to the myocardium, and we inject some gadolinium, and we watch and see during this sequence, we watch the inversion time. This is a sequence over time of a single heartbeat, and we watch the inversion time and see what it takes to null the myocardium. And this is time 0, and then as we go through, the myocardium's already nulled. Looks like the blood is nulled and the myocardium at the start of this. I usually see that there's black blood and the myocardium is visible. Black blood and a non-nulled myocardium. Nulling the myocardium means we want to make it black so we can distinguish gadolinium in interstitial tissue. And there is some gadolinium. We injected some. There's some gadolinium in this interstitial tissue right there, and up in here too as well. So we can already see that, but we want this to be black. So we want, there it is, we want to null the myocardium. Obviously, we're not nulling, which is the area where the gadolinium is, except for when we null the blood pool. Even knowing the blood pool doesn't null the amount of gadolinium that's gotten into the inferior apical portion of the left ventricle there. Septal, inferior septal, maybe mid. And so there's lots of gadolinium gone into this area of the myocardium, but we have successfully nulled this part of the lateral wall, this big hunk of the septum, but we haven't successfully nulled that, and that, which is basically gadolinium enhancement. And then we come all the way out till it's white on white. So let's go back. Now, in amyloid, you can't null normal wall because there is no normal wall. There's amyloid everywhere, and so we're unsuccessful at nulling the myocardium. And so we think there's something wrong with our coil. We don't think there's something wrong with the patient's heart, but there is. So this wouldn't be amyloid because we are able to null big hunks of the myocardium. So there we go. And there was actually a time when this nulled. It nulls about 180 usually, 180 milliseconds as an inversion time. So this is important. Looking at these early segments of something called the look locker. This is the look locker. So to be LL, when you look on the MRI, you'll see an LL. Look for the LL. When you find the LL, that's the look locker, and that's before the sequences of late gadolinium enhancement. And there is gadolinium enhancement. It is there. Okay, so we know it's abnormal, but we are able to null parts of the myocardium. So let's go look at the, where's my next one here? Do you know where I am? Here we go. So we're going to look at nulled myocardium now. And there it is. There's the nulled myocardium. There's nulled myocardium. Same hunks we saw before. And now we've got, here's endocardial late gadolinium enhancement. Sometimes you see blood pool in here, which is an artifact. That's not blood pool. That's endocardium. So we got endocardial. Over here, that's endocardial. It's on the right side, endocardial, subendocardial. And then we've got big hunk of the septum. That's very, very bright. And then as we go through here, so apex, subendocardial, no epicardial, subendocardial, septum, huge hunk of the septum. Let's go look at some more. That's our attempt to null. That's the look locker. Now here's after the look locker. The areas we saw with the look locker involving inferior septum insertion, so to speak. You got the endocardial, subendocardial wall of the septum in the right ventricle. See that? Transmyocardial in terms of the septum. Almost transmyocardial down here. Doesn't quite get the epicardium. Right ventricular insertion point down here. Right ventricular insertion point up here. Another hunk, big chunk of interstitial gadolinium that's giving us these bright images. And then this is probably normal in here because that's the trabeculae. Already seen that one. Haven't seen this one. Again, anterior, septal, anterior wall, apical, subendocardial, transmural. Even here in the lateral wall. And then bunches of normal, so it's not amyloid. You see bunches of normal, it's not amyloid. So such a diffuse pattern suggests myocarditis, sarcoid, such a diffuse pattern. IHSS, you can get the septal with IHSS. You can get the septum just in the septal thickness area. Inside, usually, there's an infarct, or subendocardial, there's an infarct, where it outgrows its blood supply. This is certainly a lot more than that. And you can see stuff on the right ventricular side as well. And then there's normal. There's big, long pieces of normal myocardium. So it's sketchy. Here's the aortic valve on FOSS. We can see it's tricuspid. It opens. You can see it doesn't quite seem to close. There's probably a little aortic regurgitation coming out of there. In that dark area. And I think we've, let's see, there may be another piece. I think we've seen it all. Diffuse, myocardial, confluent, transmyocardial, endocardial, not particularly epicardial, which amyloid is usually epicardial. But we look for hyaluradenopathy. Great opportunity to look for hyaluradenopathy because we've got great pictures. And we can look and search, and there is no hyaluradenopathy and no evidence of lung disease. And so without that, you certainly wouldn't suspect sarcoid. I don't see any areas lighting up. So I think we've learned how to look at late gadolinium enhancement and how to better understand it in terms of discriminating sarcoid, amyloid, myocardial infarction, diffuse disease, myocarditis. So let's move on. So we say, yeah, there's some asymmetrical septal hypertrophy. There's a ratio of 1.3 or greater to the posterior wall. There's septal anterior wall, late gadolinium, difficult nulling, but there are areas that you can null easily. There's also some inferior wall, anterior apical, and so a lot of stuff. Reduced ejection fraction, I'll buy that. Dilated aorta, buy that. Moderate aortic regurgitation. We've got to understand that there was a protocol that we used, and then as we go through that protocol, assessing images, we come to the point that I want to talk to you about today, which is the gadolinium enhancement images. And basically we do a look locker, and then after we do that, we acquire images with gadolinium present, and we look for interstitial gadolinium, whether it's stretching the interstitial space and the space gets larger and there's more gadolinium, or there's replacement with fibrosis, which has a greater spacing than myocardium, and so there's room for gadolinium to get into the interstitial space, and we can tell how much there is, and we can measure that directly, or we can measure it sort of indirectly and say, oh, it's a lot or little. And we're looking at inversion time. The inversion time is the time it takes for that to become black, which means there's no signal. And so we're looking for that time, which usually is around 180 milliseconds or so. And so we're trying to distinguish that point so that there's a differential between where the contrast is in the myocardium and the nulled part of the myocardium, which is black. So we're creating that. We're creating that. And so that's our whole point, is to create that. And here's some sequence to show you. 180 milliseconds, nulling the myocardium. Very effective. Usually we start out, it starts out sort of light, 60 milliseconds. Then we get black blood. Black blood Nulling of the blood pool precedes nulling of the myocardium. Black blood. Then we move into myocardium is nulled, okay, and then we move on with washout, and then we have, as it inverts, inversion time gets longer, we have a wider, and it returns pretty much to what it sort of looked like before to start with. And so that's the sequence that we're looking at that you have to understand and that you have to look at. The features you're going to see all the time of acute and chronic myocardial infarction, we'll have to bring some of those and show them to you of what's happening. It's really interesting what happens to the myocardium in terms of coronary artery disease, because it's very similar to what happens to the wall of the coronary artery with atherosclerosis. And so what you see is you see myocardial muscle, and so you see normal wall in the artery, and then you see some lipid, and you see some lipid in the myocardium because we replace this fatty replacement of an area of infarction, and then the lipid gets fibrofatty, and then it gets fibrosis, and so you see fibrosis, and then late it becomes calcified. The same sequence of events of repair that takes place within the wall of atherosclerotic coronary arteries, which is very interesting. And so, but we're looking at a different kind of sequence as we're looking for. We're looking for the myocarditis sequence, which is not accompanied by fatty replacement. We're looking for the sarcoid sequence, where there is replacement of myocardium by sarcoid or by amyloid, but we don't see the process of going from fatty to fibrofatty to fibrous to calcification. So features of chronic MI, well, let's look at this. This is good because this shows transmural. That can be infarction, myocarditis, sarcoid. But I want you to notice sarcoid and myocarditis are patchy, subendocardial, and transmural, and can be the great mimickers of any of this. And so we go subepicardio, myocarditis, sarcoid. We go subendocardio. You have a subendocardial myocardial infarction. You've got amyloid and other stuff. Let's go over here, and we get in the middle. Well, I see that in hypertrophic cardiomyopathy all the time. There's a scar in the middle where it's outgrown its blood supply, and there's a scar in the middle. Dilated cardiomyopathy, okay. Pulmonary hypertension, yeah, we did the COMPASS study, and we saw some of that. How about patchy? Well, patchy is just sort of scattered, and amyloid is very characteristic of patchy. So is myocarditis, so is sarcoid. So sarcoid and myocarditis become the great mimickers in terms of the distribution. More about the distribution. Again, subendocardial infarction, transmural infarction, amyloid being shown here. Amyloid also, sarcoid down here, epicardial, amyloid down here, subendocardial. Sarcoid myocarditis being all over the place. HOCM being usually septum. So you get sort of a formula here of what you want to look for. Can't overemphasize the differential diagnosis of LGE. So this is what you're going to always be looking for, what you're going to be looking at. And so if I said this was epicardial, I'm sorry, it's amyloid is subendocardial or endocardial. So you can see again, sarcoid, myocarditis are the great mimickers. Very confusing. Idiopathic HOCM, septum, just in the septum, areas like that. Oh, sometimes you can see the whole septum or the apex if it's tunnel left ventricle, the Japanese style, if apical hypertrophy, you get an infarct out there, you get an aneurysm. So there's some difference in terms of which HOCM you're talking about. The sequence is very important. The sequence starts out dark blood. Dark blood, this is time 0, dark blood, and then we go through this inversion time with gadolinium, watching to see what happens. Here's the gadolinium pool. It's starting to distinguish itself. The gadolinium pool is still there, and we're seeing the myocardium is being nulled. This is a great one. This is the nulled myocardium. So this is the one we're going to use. The inversion time for the rest of our images is going to be whatever this is, and I can't see what the time is, but it's 251 milliseconds. So not 180 this time, it's 251 in this particular sequence, so that's what we're going to use when we visualize the other segments. and then you can see it's coming through, and then we're going to get into a whiteout where everything is sort of light. So, and actually, it would start out, if we actually went back a couple sequences back over here, it would be sort of starting white, and then you'd see the black blood up here, and then the black becomes white, and then the myocardium becomes black. And so that's the sequence of events that we look at. Our sequence that we look at on our studies, we have to start at the end because it's reversed. So we go the same thing, though. We do the same thing. Actually, it's flipped down here and goes that way. And so you can actually plot this, and you can see this is white on white, and then we're going down this way, and we're getting intensity, Gado, nulled, myocardium is nulled, and then the myocardium is becoming white, 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 and then it's white on white again. So the same thing. This is about the 250 on this particular patient, and we just plotted it to show you what's happening on an area. You can pick an area and watch it. That's what we did. See, there's the area we picked, that little red box. Pick an area, plot it. Okay, and so here, this is hokum. This is probably a more extensive scar than I've seen. I see just little streaks inside. So that's a big scar in hokum. That's almost like you did an infarct and you put some alcohol in the septal perforator, because that's what you see. It probably was. That probably was when they're trying to ablate hokum. Here's some inflammatory disease. Well, let's see. Looks like our patient, somewhat, doesn't it? We see the septum down here. We see the inferior, all this area. We see this area up here. We see nice black blood there, nice black there, so it's not amyloid because it's not diffuse enough. We don't see subendocardial, so it's not amyloid. Could be sarcoid, could be myocarditis, two great mimickers. Certainly not coronary artery disease. And so again, we can't overemphasize how important it is to localize these areas and to understand what's happening here diffusely. And here's your amyloid everywhere. Amyloid's everywhere. Matter of fact, you try to null the myocardium and you can't even null the myocardium because there's so much amyloid. And so you think there's a technical problem with your system, but there isn't. And so you can look at this patchy. That looks like, septal hypertrophy, and then these little patches in here. And so you'd think that would be hypertrophic cardiomyopathy. This one going like this in the center, that looks like, I'm not sure, that's probably cardiomyopathy or something. And then this one looks like subendocardial infarct, almost transmural. And then we can go over to D, and we got this area, not subendocardial, but myocardial. A little bit, not epicardial. This area, kind of diffuse, probably myocarditis. This one is, looks like diffuse, looks similar to myocarditis. If it's similar to myocarditis, it's the great mimicker, sarcoid. So sarcoid and myocarditis look the same. Can't distinguish the difference, so you go look for Hyler nodes and other characteristics of sarcoid. This is doing different techniques to show you the pathology, and just the important thing here is to show you the pathology and what it looks like inside there on the collagen when they stain it. And different techniques can produce different imaging amounts of late gadolinium enhancement depending upon your technique if you're going to measure the amount. And so this is somebody that's doing a presentation in hypertrophic cardiomyopathy. And so that sure does look like hypertrophic cardiomyopathy. And yeah, there's a couple little islands of scar tissue with late gadolinium enhancement. And so that looks like what I see. That makes sense. This one, that could be myocarditis, that could be sarcoid, that could be any number of things. Turns out that this is an example of just showing hypertrophied septum. I can't tell it's hypertrophied there. Scar tissue in it. I would not be able to tell you what this one is on just this image. And then this one, some little pieces. I don't know what that means, so I can't tell you about this one either. But they're claiming again that hokum can be a little bit different than we expected, and I think it depends on what hokum it is. If it's apical hokum, or if it's septal hokum or lateral hokum, depends on where the hokum is. And so our patient What are we looking for? What are we trying to tell? Well, we're interested in nulling. We showed you our protocol. The LGE helps us narrow down a differential diagnosis of non-ischemic cardiomyopathy. And we talked about our sequences and how they differ from other sequences. It's just backwards, and all we have to do is read it the other direction. And so diagnosis, aortic regurgitation for years would explain the chronicity of this guy's findings and his EKG voltage. Ejection fraction is not surprising that they got 34%, they get 29%, they get 42%, and it's these are comparing apples and oranges. And so the MRI is supposed to be the gold standard of ejection fraction because of our stack of short axis images, and so it is, and we get a 50%, so I think we're happy with that. And there's some regional dysfunction. Palpitations, well, we certainly, on a guy who has big hunks of late gadolinium enhancement, need to look at palpitations because, well, he doesn't have a real low ejection fraction, and he doesn't have syncope or near syncope, he doesn't have a family history of syncope, near syncope, or sudden death, and he doesn't have episodes at night. His EKG doesn't show any problem with dispersion, and but he does have potential macro reentry circuits, and he deserves at least a ZIO, although we don't think he's at risk of sudden death. I would want to see a ZIO. And so does he have ASH? Does the architectural findings of the ventricle change with infiltrative cardiomyopathies? Well, yeah. I mean, I think there's some change with sarcoid and amyloid, and there's a lot of bulging, and septum gets fatter. And with HOCM, there's some changes where you can actually get scar and infarct to the apex and little infarcts in the septum. So the architecture does change. There is some remodeling that takes place. But the tall voltage certainly mitigates against there being sarcoid and amyloid. There's no way you can have that kind of voltage on EKG on this guy, you know, who's average size and get sarcoid or amyloid. Too many areas for amyloid, too many normal areas. Amyloid's going to be diffuse. It's going to be subendocardial. EKG voltage is too tall for amyloid, too tall for sarcoid. Diffuse nature suggests sarcoid, but no Hyler nodes or other node features. And we actually combed that MRI looking at the septum for nodes and couldn't find anything. And so myocarditis years ago versus sarcoid without Hyler nodes, I don't think sarcoid is going to happen without Hyler nodes and low voltage. So I'm going in favor of this guy having aortic regurgitation and having burned out myocarditis, and the ASH is a red herring on him. And so that's my favoring in terms of diagnosis. I hope you enjoyed this presentation. I hope you have a better concept of what to look for in MRI sequences, because it's so very important. It will be on the boards. It will be on the boards. And so we want you to understand this. And certainly we want you to understand one particular slide, and that's this one. We want you to understand this differential diagnosis of late gadolinium enhancement. You can try memorizing it. It's hard. Sarcoid and amyloid. Sarcoid and myocarditis are the great mimickers. Just remember that. Anything can be that. Got IHSS. You look for the asymmetrical subplot hypertrophy and look for a scar inside. And of course, there can be some crazy ones too as well, which is cardiomyopathy and big dilated ventricles. So that's the main take-home point. Take this home with you. Look at it. Here's one slide. That's the only slide you need to know. And you just got to look at a lot of these. So thank you very much. I appreciate your coming today. We'll see you next week. Bye-bye.